The anterior cruciate ligament is a centrally located intracapsular structure, but it is extrasynovial. These are anatomic features that are shared by the posterior cruciate ligament. Together, as you can see here, a portion of them form a triangle, here shown in a single MR image and in the specimen. Between the triangle is located fat, and that fat, therefore, is extrasynovial. The importance of that particular observation is if indeed there is an injury to the knee and you can be certain that there is fluid in that triangular fat between the anterior cruciate and posterior cruciate ligament, it is very suggestive that the overlying synovium has been disrupted. And if that is the case, there is a risk, of course, that the image is also showing tears of the anterior cruciate ligament or posterior cruciate ligament, or of both structures. So when you see fluid in that triangle between the two cruciate ligaments, and I'll show you an example later, although it is not a common finding, it is an important finding to observe. I indicated that there is a great deal of recent interest in the two bundles that make up the anterior cruciate ligament. And the reason is, of course, that now two bundle reconstructions are being done. There's a huge debate about the benefit of taking the time of doing individual bundle reconstruction as opposed to the usual way that ACL reconstruction is accomplished. It's more time-consuming, it is more technically challenging, and the literature is not clear whether or not this technique really has a benefit. Those who believe in it would point to some of the facts that are on this particular slide, including that the bundles of the anterior cruciate ligament are lax and tight at different knee positions, and that some would argue even the function of these bundles is different. It is said by many that the anteromedial bundle is the primary restraint against anterior translation, particularly in knee flexion, and that the posterolateral bundle is the primary restraint against rotational forces, particularly in extension of the knee. So if this is the case, you can imagine that the good examiner, again armed with a number of provocative tests, could sort out in cases of partial tears, in fact, what bundle might be involved. With injuries to the anteromedial bundle, the anterior drawer test is better than some of the rotational tests that are accomplished. And in the opposite, with injury to the posterolateral bundle, it could be argued that it would be the rotational test that would be more sensitive to injury. We'll touch upon partial tears of the anterior cruciate ligament a little bit later. I've indicated already that we name these bundles according to where they attach to the tibia. It's not always possible to do this, but in some cases it is made more evident because there can be small collections, linear in nature, of fluid between the two bundles. In some reports years ago of arthrograms that were done in the knee, there was sometimes fluid that would actually get into this space between the two bundles, and it was considered a normal finding. I'm not sure if that is the case, but sometimes at least there is a layer of higher signal intensity between the two bundles. If we look at the pictures at the bottom, I have kind of color labeled these arrows. The yellow arrow on these coronal images is pointing to the anteromedial bundle, and the orange arrow is pointing to the posterolateral bundle, and you can compare those with the pictures, beautiful pictures from an article in Arthroscopy. The anteromedial bundle is longer, and I think in general is easier to see, except posteriorly at the image on your right, where you generally can see the attachment of the posterolateral bundle. So I try to trace these on the MR images. I'm not always successful in separating them, but I try to be able to see at least portions of each of those two bundles. You compare now those normal images with the images at the top, which are showing a high-grade partial tear of the posterolateral bundle, that is one with the orange arrows. And you can see that most of the high signal in this partial tear, stable knee, not operated on, appears to be within that posterolateral bundle. So that's how I try to sort it out. Now, the literature suggests that injuries are more common in that anteromedial bundle, but actually in my clinical practice that it's about equal. Now, of course, many of those cases are not proved operatively because partial tears of the anterior cruciate ligament may not be surgerized. It really depends on whether or not the orthopedic surgeon considers the knee unstable, and I'll get back to that point a little bit later. If you go ahead and look at the footprint, again, the word footprint, which keeps coming up in the orthopedic literature, this is a nice demonstration of the landmarks that are used to be certain that in surgery the footprint is being reconstructed properly. There are two ridges on the inner aspect of the lateral femoral condyle, a more anterior one known as the lateral intercondylar ridge, and a more posterior one known as the posterolateral rim. The femoral attachment of the anterior cruciate ligament is between these two ridges, and these are used really as guidelines, in fact, during surgery. It's of interest that the more anteriorly located lateral intercondylar ridge is sometimes called residence ridge, because sometimes that bump is mistaken for the posterolateral rim. And if you make that mistake, then you're going to place the reconstructed ligament too posterior in the lateral femoral condyle. Really, in reality, those bundles attach between those bumps, the anteromedial bundle above the posterolateral bundle, again being longer than the posterolateral bundle. There's an interesting phenomenon that one of our previous fellows has brought to my attention that I can't say is true or untrue yet because we haven't done the work to verify it. But she has noticed that there is an excrescence that develops sometimes where the anterior cruciate ligament attaches, perhaps representing enlargement of the residence ridge. So this may be another example of an enthesophyte developing when you've had an injury to the anterior cruciate ligament. It's something to look for. Again, I don't know the value of this yet, and it may be a degenerative phenomenon, but I have seen a few cases where indeed this is the case. There are anatomic variations in the size of the anterior cruciate ligament, this one being described in the orthopedic literature about 7 years ago. Designated a deltoid triangular anterior cruciate ligament, the arthroscopy picture at the top right, it is very broad and likely more vulnerable to injury. It does not have individual bundles, it would seem, but it is crowded into that small space of the intercondylar notch. And I have no MR case that has demonstrated this sort of pattern. One other anatomic variation that I would point out, I don't have a slide to show you, but there are reports now of a third bundle of the anterior cruciate ligament located between the other two. So maybe more than two bundles, I'm not sure. Despite those reports of a third called an intermediate bundle of the anterior cruciate ligament, most of us still go with the assumption that we're dealing with a two-bundle type of structure. I've already pointed out the importance of the geometry of the intercondylar notch through which the anterior cruciate ligament and posterior cruciate ligament pass. There's a lot of interest about why it is female athletes more than male athletes who are particularly prone to develop tears of the anterior cruciate ligament. And a lot of theories have been developed to explain it, including differences in ligament laxity in men and women. One of the theories suggested that the intercondylar notch in women is in fact narrower than that in men. But counteracting that, of course, is that the ligament size is smaller in women than in men. So it isn't entirely clear why it is women who are particularly prone, when involved in athletes, to develop athletics to get tears of the anterior cruciate ligament. I also pointed out in an earlier talk how rotation can affect the normal entwining of these ligaments. Clearly, it is internal rotation that is most dangerous for these ligaments. Many people in articles on the anterior cruciate ligament stress, in fact, that it is internal rotation of the tibia that is the main mechanism of injury. And for many years when I gave lectures, I would indicate that, telling you should really look for this abnormal internal rotation. And I would use slides like that, shown here, to point out why. Well, that doesn't seem to be the case, and I would suggest if you want to prove that, you go online and you look at pictures of athletes or even movie clips of athletes who, during their athletic endeavor, develop anterior cruciate ligament tear. And I would say 90 to 95% of them, I've looked at a lot of them, it is not internal rotation, it is external rotation of the tibia. And with external rotation, it can be unrelated to an external force, which is very common, particularly in tennis players, or it can be related to an external force that produces external rotation of the tibia. So despite the evidence on this slide, I just can't believe internal rotation is the major mechanism for tears of the anterior cruciate ligament. Having said that, however, I can tell you that when you look at your tears of the anterior cruciate ligament with MR imaging and you go to your sagittal images, almost invariably it is the lateral tibial plateau that is translated anteriorly with respect to the lateral femoral condyle, whereas a normal alignment, at least on MR, appears to be present on the medial side. If that's the case, that is a position of internal rotation of the tibia. So that is what you'll see almost all the time on your MRs when there is translational abnormality of the tibia. I also pointed out the vulnerability of this ligament with hyperextension because of the nearby, sometimes sharp, intercondylar roof. I'll remind you how we quickly check the ligament. We do this routinely, not drawing the lines, but thinking of them mentally. That the line of the intercondylar roof, trace the ligament. Again, they're either parallel or, in fact, the ligament line is somewhat steeper, not much steeper, but somewhat steeper than the alignment of the roof. Now, one of the things that I found out early on, it's not so much a problem anymore with higher resolution images, but as you trace that anterior cruciate ligament up, you sometimes run in with a partial volume effect, particularly with regard to the lateral femoral condyle, and that's what we're seeing here. And sometimes it's low signal rather than high signal on the surface of that condyle that will make you think not only that the anterior cruciate ligament is abnormal, but it is thickened. This is a partial volume effect. So a number of years ago, we looked at whether or not imaging the knee with 10 degrees of flexion would help. When you flex the knee, you separate the roof of the intercondylar notch from that more superior half of the anterior cruciate ligament as shown here. And it does help, but the problem is we never verified whether it would make assessment of other structures of the knee more difficult. So this is not something we routinely do. However, as you know, following injuries, often the patient is examined in MR with some degree of knee flexion. And I think that helps us in the assessment of the anterior cruciate ligament. The use of reformatted images, I don't think they're necessary unless you're dealing with low field strength magnets, and then they may become essential. There are a number of ways that you can do the reformat. This is one technique, sagittal oblique images. Here's the tear, and you can even go further and do other coronal oblique images. There's the tear on that. We do read for several sites that have very poor quality images. There are many of them when I'm reading those cases, particularly if Minnie is there the day before, because she refuses to read those cases. But I have found at many of those sites, they actually do include a coronal oblique image as part of their examination, and it often is the one that shows the anterior cruciate ligament the best. Let's talk about the classic manifestations of injury. Many patients who have tears of the anterior cruciate ligament will tell you that there is a pop. You may not hear it, you feel a pop at the time of the injury. And it is suggested that the construction of the anterior cruciate ligament is somewhat unique. It's not totally unique, but it is somewhat unique because the arrangement of the collagen fibers within the anterior cruciate ligament, in fact, has fibers that curve around toward the surface of the ligament. This is called a helicoid type of arrangement. You know, in that discussion that I gave earlier, I showed you longitudinal collagen fibers, which make up the major bundles that we see in ligaments. But there are other fibers. I didn't get into them. And in the anterior cruciate ligament, there are prominent helicoid curving fibers. And it is suggested it is the bursting of these helicoid fibers that account for like a convulsion of the ligament and lead to the sensation that is described by the patient as a peculiar pop. And as I indicated earlier, it is the helicoid fibers that probably explain that recoil that occurs when we have that part of the torn ligament projected anteriorly into Hoffa's fat pad. You don't see that with medial collateral ligament. They don't have helicoid fibers. Other ligaments may, but not supposedly the medial collateral ligament. The second manifestation of the injury is the effusion. Typically, with a tear of the anterior cruciate ligament, there is a slow accumulation of joint fluid, usually beginning several hours after the injury and increasing for the first 24 hours. The reason it is believed that the vascular supply to the anterior cruciate ligament is somewhat tenuous, it is small, and when these vessels are broken or disrupted, it drips much like a leaking faucet. So if you have an immediate effusion, particularly if it is bloody, one of the possibilities to consider is an osteochondral fracture accompanying that anterior cruciate ligament tear. You may not have an effusion at all because as you tear the anterior cruciate ligament, you may in fact develop tear of the posterior capsule. This is an example where you can see all of that edema that was involving the posterior capsule. The posterior cruciate ligament was all right in this case. I did not include it in this image. The posterior cruciate ligament is more intimate with the posterior capsule, so the same phenomenon is more common when you have posterior cruciate ligament tears. There are several advertised mechanisms of injury to the anterior cruciate ligament. These are the three major mechanisms. The first one is a change of direction with deceleration with the foot fixed on the ground and typically with contact with another player. This likely leads to external rotation of the tibia at the time of impact, forms the basis for the O'Donoghue's triad with additional injuries to the medial meniscus, certainly, and to the medial supporting structures. The second mechanism is a change in direction with deceleration, as with the first, but the foot is fixed and there is no contact with with another person, so no external force. This can be associated either with external rotation of the tibia or with internal rotation of the tibia. Based on anatomic evidence and what is reported in the literature, the pop may be more characteristic of internal rotation of the tibia than external rotation. And the third was the mechanism I illustrated previously. It relates to that boot mechanism that occurs in skiing when a portion of the ski contacts the ground, but the foot of the ski and the leg keep running forward. What happens, you activate your quadriceps muscle, an antagonist to the cruciate ligament, anterior cruciate. You end up with anterior translation of the tibia. You regain your balance. That's the good news. You tear your anterior cruciate ligament. That is the bad news. I commented before on the patterns of bone contusion, indicating that it is very, very difficult, based sometimes on these bone contusions, to know whether you're dealing with a rotational injury or a pure translational injury or both. These are characteristic patterns that we see, and I showed you some examples of this. What is said about them, and I'll repeat, is that the edema is more anterior on the femoral side than on the tibial side, as you can see here. And the edema is closer together in the medial compartment than in the lateral compartment. There's a reason for that, which I won't go into, but it has to do with the surfaces of the tibial plateaus, which are different on the two sides. Some people say that the edema is located slightly more anteriorly in the lateral femoral condyle. Now, a lot has been written about these patterns of marrow edema. In general, I am very comfortable with a case of an acute tear of the anterior cruciate ligament when the marrow edema is just on the lateral side. I call that a simple tear of the anterior cruciate ligament because it is generally easier to figure out what's going on. Once you get edema on the medial side, it becomes a lot more difficult to figure out mechanisms. There's a nice article years and years ago that the cause of edema on the medial side was a contra-coup mechanism, much like we get with the pivot shift test that is used to study the anterior cruciate ligament. So there might be an initial internal rotation of the tibia, and then it bounces back with external rotation. You get a closing down of the medial compartment and a contra-coup pattern of marrow edema. It's a very nice article, and Phoebe Kaplan is I believe, the lead author. Right in front of or behind that article is an article that we wrote that said, well, there was another reason for edema on the medial side, particularly in the medial tibial plateau, related to avulsion injuries of the semimembranosus. And I'll show you some examples. I don't think either of those articles explain the common occurrence of edema on the medial aspect of the knee with injuries to the anterior cruciate ligament. And I would again remind you that when you see this pattern, it may be rotational injury or translational injury that does this. A good orthopedic surgeon will tell you that he or she, if the examination is done carefully, can diagnose a high-grade partial tear or a complete tear of the anterior cruciate ligament. And if that is the case, in fact, why do we get these MR imaging examinations? So I spoke to several orthopedic surgeons at a meeting we did at the academy, and I constructed this particular list, which is generally why they will tell you they ordered the MR examination. Uncertain or occult clinical diagnosis, they're not sure what's going on, they don't often admit to that. Difficult physical examination, a suspected meniscal injury, more about that in a minute. A suspected occult fracture. They want to know if in fact there is significant bruising, and particularly if there is a fracture. They're concerned about injury to other ligaments. The clinical examination is more difficult when there are multiple ligaments that are abnormal, and in the postoperative period. But again, when you talk to orthopedic surgeons, they will also tell you one of the reasons that they get this is, in fact, that the patients insist on a MR examination. Their friends have had it, and they want an MR examination. And in general, rather than arguing with them, they go ahead and order the MR examination. But the point I would make is it is true that good orthopedic surgeons generally know when there is a tear, an unstable tear of the anterior cruciate ligament. So the information they may want when you read the MR is not for you to say, yes, you're right, there is a tear of the anterior cruciate ligament. Rather, they want some additional information. Now, because this is a lecture on the anterior cruciate ligament, I'm compelled to show you one example of a acute, complete tear of the ligament. Here we can see that the course of the ligament is depressed. There's a lot of high signal. There is a gap, and these gaps can be very prominent, again, related to recoil of the ligament. That's an acute, complete tear. It would look pretty similar in the subacute stage as well. And I'm also compelled to show you one chronic complete tear shown here. In these cases, the ligament fibers are obscured often by fibrous tissue, and I'll get more into the patterns of fibrosis later. So that's your acute complete tear, and this is your chronic complete tear. And even when the tear is chronic, there may be lingering bone contusions still seen on the images because they take a while to go away. Now let's look at a few cases that kind of emphasize why the orthopedic surgeon may have wanted to order an MR examination. The first of these is a case of an acute complete tear of the anterior cruciate ligament. The orthopedic surgeon has examined the knee, feels very, very comfortable that the anterior cruciate ligament is torn, and actually is not particularly interested in our saying, yes, it is torn. What that orthopedic surgeon may want to know is further information about the presence or absence of a meniscal injury, or perhaps other ligament injuries as well. Now, in the acute setting, it is often the lateral meniscus more than the medial meniscus that is torn. The reverse is true in the chronic setting. On clinical examination, diagnosing tears of the medial meniscus is said to be easier than diagnosing tears of the lateral meniscus, particularly in the setting of a tear of the anterior cruciate ligament. So, indeed, they may order an examination looking at the menisci. This will influence their management issues. So in one case of a complete tear of the anterior cruciate ligament, this was what the MR showed. You've seen this case before. Remember it as the large radial tear, no missing fragment, just opening up like a book at the site of failure. That was significant information to the orthopedic surgeon. Another bit that may be significant, and we recently had a nice case of this, is an actual avulsion of the anterior cruciate ligament right at the femoral attachment. This is not common, and I would caution you that even though you see a tear involving the proximal third of this ligament, you want to be careful not to say it's right at the femoral attachment unless you are sure that is what you are seeing, because that is something that could be repaired rather easily compared to a tear in the midsubstance, and it may change the way they treat that torn anterior cruciate ligament. And even in this case, okay, you can argue that there is a little bit of tissue still attached to that femoral condyle. So I have seen very few of these, okay, and I'm sure you have not seen many of these either. Similarly, as I showed in one of my earlier talks, the posterior cruciate ligament may tear from its femoral attachment, and that's an important observation to make. There are a number of osseous and cartilaginous findings. They've been touched upon at various times during this course. I'm going to go through some of this fairly rapidly. These take the form of bone bruises, osteochondral and chondral fractures, and avulsion fractures, of which I will emphasize 3. The osteochondral and chondral fractures and bone contusions dominate on the lateral aspect in this distribution that you know full well. The lateral femoral condyle at its mid-portion and the lateral tibial plateau far posteriorly, sometimes even involving the vertical segment of the lateral tibial plateau located very far posteriorly. We've already touched upon in several talks the importance of looking at the depth of that condylopatellar sulcus on the lateral side. Typically, it is about 1 millimeter in depth. If you draw this line, which is sometimes a little hard to draw, if it's greater than 2 millimeters, it is abnormal. This is an osteochondral fracture that is pretty specific for a tear of the anterior cruciate ligament. And almost always it is, in fact, it is an unstable tear. It could be partial, but it would be high-grade partial tear. I agree with what Minnie said, that sometimes the osteochondral fractures that accompany certain lateral patellar dislocations can fool you. And further, I would emphasize that although the typical osteochondral fracture occurs right at the groove, shown here, it can vary a little bit, as I'll show you in an example. But in any case, these measurements are helpful, particularly on plain films, which hopefully is the first imaging method you use. Here's an example of a deep notch, obviously deep. This is indicative of a tear of the anterior cruciate ligament. A long notch probably has the same significance. I don't have a measurement to tell you, but the longer the notch, the more likely you're dealing with an osteochondral fracture. And the one that is most interesting to me, that I've seen more often in children than in adults, is a double notch. A double notch should not be normal, and you can see it here. Well, let me put this here. You can see it here. It's a double notch like that. In all of the cases that I have seen of a double notch, the edema is seen in the posterior notch, not in the anterior, which suggests that maybe the anterior notch is the normal lateral condylopatellar sulcus, and the fracture in children may occur slightly posterior to that particular region. We have a whole bunch of these, and in fact, I know there's some research fellows here, but this might be something that could be investigated still further, looking at the nature of this double notch on the lateral side. If we stay on the lateral side, the other place that we look for osteochondral fractures is in the very posterior aspect of the lateral tibial plateau. Now, just because we can say with confidence we're dealing with an osteochondral fracture back here, I am not certain it has any clinical significance, because we're way, way back in the lateral tibial plateau. At a conference recently, it came up, this particular finding, and I remember we were going back and forth. In my view, if you have cartilage, there is a function to that cartilage. And indeed, this is anything past the sulcus is weight-bearing. Anything posterior is weight-bearing. So this has got to be a weight-bearing surface, even though it seems like it is sloping down and doesn't make a lot of sense. So it must have a function, or there would be no articular cartilage in that region. We went ahead and looked at a whole bunch of these, and let me enlarge 3 of them. Typically, but not invariably, if you look at the contours, you go from the peripheral aspect to the central aspect. On the lateral side, there will be a shallow notch peripherally, and then it becomes a straight margin, and then it becomes convex as you reach the central part of the joint. So we tend to call these, if there is marrow edema and there is some deviation in this plan of contour change as we go lateral to medial. Here's an example of what we would call an osteochondral fracture involving the posterior aspect of the lateral tibial plateau. Here's another example of what we would call an osteochondral fracture of the posterior aspect of a lateral tibial plateau. Patient had lateral meniscal pathology as well. So in any case, we mention it, we call it a fracture. Does it have any clinical significance? Probably not. Now we get to the so-called complicated ACL tears, because we're going to deal with problems on the medial side. And in my view, if you have an ACL tear and you have edema on the medial side, particularly in the medial tibial plateau, and especially if it is dominant posteriorly in the medial tibial plateau, it is extremely likely that you have a tear of the posterior horn of the medial meniscus, or a meniscocapsular injury. So as shown here by the arrow. So I become extremely critical about any signal intensity adjacent to the posterior horn when there is edema in that medial tibial plateau. Earlier on, I touched about the difficulty of diagnosing meniscocapsular separations. I rarely call them. If it's a separation and you have a joint effusion, there should be fluid in that gap. I don't see that often. What I see is edema in the meniscocapsular tissue adjacent to the posterior horn, and I call these meniscocapsular injury. Whether it is a contra-coup effect, I'm not certain. It may be, but at least look for that, particularly when there is injury to the medial side. And here's another example where there's edema in that medial tibial plateau, and you can see the contour alteration in that subchondral bone plate. It is depressed, and there was loss of cartilage. So based on the terminology we introduced earlier, this is an osteochondral injury, manifest as a chondral fracture with a chondral defect, manifest as depression and irregularity of the subchondral bone plate and with a bone contusion in the subjacent bone. And as you look at it, it is also manifest as a tear very close to the meniscocapsular region of the posterior horn. So there's a definite relationship here between the bone findings and the meniscal findings. There are 3 avulsion fractures that may accompany tears of the anterior cruciate ligament. Many talked about some of the important injuries of the semimembranosus tendon and all of its arms. And we have seen examples of avulsion fractures of where at least one of these arms attaches to the tibia. And this is the kind of bone fragment that you will see. Now, many years ago, I learned that in the normal situation, there is a figure of 7 configuration to the posterior aspect of the tibia. And the posterior cruciate ligament avulsion will interrupt that figure of 7. Well, here the figure of 7 is intact. I hope I pointed to it correctly, Minnie. That's Minnie's observation. But in any case, this is an avulsion fracture. And the ones I've seen, and now I've seen about 5, I think I'll show you 2 or 3. There tend to be kind of little slivers of bone, often shaped like you see here. I have not seen a case where I've had this avulsion fracture and there hasn't been a tear of the anterior cruciate ligament. Here's another one, this one a little bit larger, okay? And you can see in this case, even though an avulsion injury, that there is considerable edema in the subjacent marrow. And here you can see the tear of the anterior cruciate ligament. The second avulsion I would talk about is the avulsion of the intercondylar eminence of the tibia. This injury is seen more common in children than in adults, and is said to be related mainly to rotational force. There are a number of other things that occur. Now, we typically think of when ligaments avulse bone like this, and this is from the anterior cruciate ligament, that's the point of failure. But it's been pointed out that at least if you test those ligaments and sample them histologically, they've been injured elsewhere as well. You don't just rip off a piece of bone and have a normal ligament attached to it, but there may not be a significant injury anywhere else in that ligament. And that rule holds not just for this fracture in this ligament, that rule holds for all ligaments, that although we can see the major site of failure, there are at least microscopic failures of that ligament elsewhere. So this is the avulsion fracture. There is a classification system that has been proposed. I show it here in a picture taken from the literature with higher numbers indicating further displacement and even rotation of the displaced fragment. And for many years, I think CT, plain films and CT were used. Now we're getting more cases where MR is used. Here's an example of a fairly displaced piece of bone derived from that intercondylar eminence. But I want to make a point about it. And because although what I'm going to show you is extremely rare, it is reported. So let's take a second case study of an ACL injury, which is acute and complete, related to a fracture of the intercondylar eminence. This is a fracture which I indicated to you, although not osteochondral at its origin, may extend over and become osteochondral on medial and lateral sides. And so these patients develop hemarthroses, and that produces an immediate joint effusion. The fragment is typically displaced superiorly, and that leads to the classification system. And anatomic reduction is the aim here. Now, sometimes that can be accomplished without surgery, but there are several reasons why you don't get anatomic reduction. Some people have emphasized that the lateral meniscus may in fact attach to this via its anterior root ligament. And as this piece displaces, the orientation of the lateral meniscus changes, and that changing orientation blocks reduction of the fragment. And that's certainly something you want to look at. And that's been described also with medial meniscus, although less commonly. But the other finding I would comment about is the intimate relationship of that anterior transverse meniscal ligament, which normally sits right in front of the anterior cruciate ligament. And so in these cases, I always take a moment to be certain that that ligament is not trapped under the fragment, as it was in this case, which I got from the outside. And in fact, this patient went to surgery. So you want to at least look for that. It's very, very rare, but it is a cause of persistent elevation of that fragment. I'll run through this very quickly. Many covered this very well. This avulsion fracture, the Sagan fracture, typically an Owry mechanism, the cause of the avulsion, as many indicated, many culprits attached to this area, and one could argue whether or not it is that lateral capsular ligament. It seems to me on most of the MRs that I've seen of Sagan fractures, there is a portion of the iliotibial tract still attached to it, so I kind of favor now it is fibers of the iliotibial tract. But as many indicated, there's a Gerdy's tubercle nearby, and it gets a little bit difficult sorting this out. We'll look, in fact, at a case study of a Sagan fracture, indicating again that these can be very small, easy to miss, easier to see on plain films, although not always easy on those as well. They may have edema, but they need not. When you see these, the ACL is typically torn, and there's a higher likelihood that there's going to be other problems in the lateral ligaments. Here, a fracture, and there was, in fact, injury to some of the superficial lateral structures. And many also pointed out that Bosch-Bach bump. As I looked at your reference there, it seems like it should be Bosch bump, and we're giving extra credit to Bosch on this, all right? But this is the Sagan fracture, and she showed a beautiful case of an initial Sagan fracture and a later bump. And I'm still not sure whether it is the fragment reattaching and joining the tibia that produces the bump, or whether it is an enthesophyte that is independent of the fragment that has been separated. But I have trouble with this because I have called Bosch-Bach bumps too many times. There are other bumps that occur near here, particularly near the proximal tibiofibular joint, where there are small contour changes in the tibia, so you have to be a little bit careful. This is a beautiful case of what a Bosch-Bach bump looks like. And here's another one. So I'm going to compare these to your examples. I like mine better, okay? But anyway, these are Bosch-Bach bumps. And many also made reference to what some people are referring to as a soft tissue Sagan injury. I have no proven cases of these. This was an example of a anterior cruciate ligament tear with injury also to some of the lateral structures at their fibular attachment, and then this focal edema right where we would expect a bony Sagan, but we could not see a bony Sagan. So this may relate to one of the arms, the anterior arm of the short head of the biceps. I'm not sure, but there are references and very little descriptions of this soft tissue Sagan injury. The other secondary findings we'll go through very rapidly. They're not very valuable. People have talked about buckling of the lower portion of the posterior cruciate ligament because of anterior translation. People have talked about the positive PCL sign where the right angle turn of the posterior cruciate ligament is seen, and when there is anterior translation of the tibia such that a line drawn cephalad from this border does not intersect the roof. But these are secondary findings and not of great value. People have talked about a positive fibular collateral ligament sign. I've never liked this, but there's a recent article actually that says, again, it's pretty good. I consider a positive fibular collateral ligament sign of anterior tibial translation when I see it on one image, yes, but also when it is lax on that image. Because I think just to say every time you see it on a single image, you have a tear of the anterior cruciate ligament, you will make mistakes. And buckling of the patellar tendon in the sagittal plane I don't find very valuable. The degree of buckling is not very remarkable, and there are other causes of this. So I don't find this useful. The anterior translation of the tibia in the sagittal plane is something I touched upon earlier when I talked about the different patterns of tearing of the posterior horn of the lateral meniscus in the early stages of an anterior cruciate ligament tear. I eyeball these. I do not measure them. But here, clearly, anterior translation of the tibia. But remember, I made the point that that posterior horn has to make a choice. And in this case, it chose not to move with that tibia. So we really have subluxations at two different levels, between the meniscus and the condyle, between the tibia and the meniscus and the condyle. So it gets to be a little bit complex sorting this out. So I don't use this often. And the shearing injury of the infrapatellar fat body is also not very helpful because of the normal recesses that occur within this structure. Typically, there's a horizontal recess at the lower part of the Hoffa's fat pad, and there may be a vertical recess at the top. I have seen cases like this where it does appear that there is ripping of portions of Hoffa's fat pad in patients with tears of the anterior cruciate ligament, but I have no operative proof that they found fractures of Hoffa's fat pad. The final sign was that fluid in the triangular extrasynovial space between the two cruciate ligaments. This is the normal we started with. Here is the abnormal. But again, I don't find this particularly valuable. It occasionally is seen as a secondary finding. Many talked about O'Donoghue's triad, and just like she was not listening to part of my talk, I was not listening to that part of your talk. But I want to just touch upon something that I think she did cover, that although we consider this a triad as shown here with an acute complete tear of the anterior cruciate ligament, some sort of injury to the medial supporting structures, and a medial meniscal tear or meniscal capsular injury, and here are those three components that we look for the classic triad. This is a meniscal capsular injury with regard to the medial meniscus. It has been pointed out that first there is a tetrad, and I think she touched upon it, where you get femoral detachment of the medial patellofemoral ligament, and there's actually now a pentad where there is an association with lateral meniscal tears. So we have seen all five. Okay, here's an example of all five, O'Donoghue's tetrad, and you can see the various types. So there are other findings to look for in these cases. Stump entrapment occurs related to recoil of the distal portion of the torn anterior cruciate ligament. It retracts into the deep part of Hoffa's fat pad, and some people think that this is the nidus that will produce a cyclops lesion when it occurs without reconstruction of the anterior cruciate ligament. There are reports of cyclops following tears of the anterior cruciate ligament. Here's an example, and I've seen these stumps retract forward with both complete tears and also with incomplete tears of the anterior cruciate ligament. Here's a couple cases that were reported. This is stump entrapment Here's what it looked like on the sagittal view. This is from one of our previous fellows. This was the operative picture of that stump that had retracted anteriorly. And several patterns have been described, some more globular than others, but here's another case from that article, stump entrapment with anterior retraction of the torn ligament. We'll move on and we'll go for about 10 more minutes. Partial tears, there's a lot of controversy regarding the definition of partial tears of the anterior cruciate ligament. In recent articles, 4 classic criteria have been noted. An abnormal Lockman test, a negative pivot shift test, okay, low-grade injury using that arthrometer that was actually developed in San Diego, and the final one, which is the proof, a positive arthroscopic examination. They're not the most common pattern that we see. They represent 15 to 20%, and I think they're extremely difficult to diagnose on MR imaging. As I indicated, some of the reports have indicated anteromedial band involvement, but I have seen an equal number, unproven, of course, but posterolateral involved. What I would emphasize is that the injury, the partial tear, can be classified as stable or unstable on physical exam. Stable partial tears carry a prognosis similar to that of a normal ligament. Unstable partial tears carry a prognosis similar to that of a completely torn ligament. So even though you're struggling, is it partially torn or not, if the orthopedic surgeon tells you the ligament is stable on physical exam, it probably doesn't matter what you're saying about it because it's going to be treated conservatively. This is one example of a partial tear, mainly of the anteromedial band, with, in fact, intact posterior fibers. They don't look perfectly normal, but with stump entrapment, as those fibers have rotated anteriorly. So we will see these, but I find them difficult. Secondary findings that we've talked about are far more common with complete tears, but indeed are seen with high-grade partial tears. This was a case from many years ago that I confidently diagnosed a complete tear of the anterior cruciate ligament, and the orthopedic surgeon came back and found me after surgery saying it was not complete. It was a high-grade partial tear. It sure looks complete to me, but I guess you can have secondary findings of bone contusion with high-grade partial tears. And in children, owing to the natural laxity of ligaments, you can sometimes get those patterns of marrow edema that we felt to be specific for tearing with an intact anterior cruciate ligament. And that was the case here. This case sent to me from Austria, actually a proven case where the ligament, and they went did arthroscopy, it was normal. A word or two about cystic degeneration of the anterior cruciate ligament. Recent articles have emphasized the predilection for the posterolateral bundle of the ligament. This can produce pain, particularly on full extension of the knee, as the thickened ligament will impinge upon the roof of the notch. This is an image I showed you before, the classic appearance, mainly in that posterior half of the anterior cruciate ligament, and you can see it on the axial images. One of our previous fellows said it reminded her of a drumstick, and so we call it the drumstick sign. This is a beautiful example of a drumstick related to cystic degeneration. And the cysts can get very bizarre, as in this case. There is an association with pericruciate ganglion cysts and intraosseous ganglion cysts at the femoral and tibial attachment of the ligament. Here's a nice example of that. So these, seen more often in older people, designated cystic degeneration, and the ligament is stable on physical examination. We'll finish up just with a few other points. The chronic tears of the anterior cruciate ligament. Look at this example. 9 months later, it would be very difficult to suggest that ligament was abnormal. This has been pointed out in the literature in several articles. I've referenced one here, that there are 4 characteristic patterns of fibrosis following complete tears of the anterior cruciate ligament. In about 40% of cases here, the blue ligament, the anterior cruciate ligament, will in fact adhere to the posterior cruciate ligament. In about 10% of cases, it adheres to the roof of the intercondylar notch. In about 10% of cases, it adheres to a lower margin on the lateral side of that notch. The orange arrows are pointing to the normal attachment site. So with all of these patterns, theoretically, there should not be ligament tissue at the normal attachment site of the anterior cruciate ligament. This can cause problems. Here's an example where this one where there was fibrosis to the posterior cruciate, and this one to the roof of the intercondylar notch. Now, this is clearly abnormal, but you could imagine that if you had a bigger ligament in this pattern, you would run into problems. And here another example where there is a chronic tear with fibrosis to the roof of the intercondylar notch. In addition, there may be complete resorption of the torn ligament. Now, this is not uncommon. I have seen this now quite a bit, where you can see no ligament in cases of chronic complete tears. The natural feeling on these is, I know, to say developmental absence of the cruciate ligament. And there are reports of that, but let me remind you that typically when there is absence of the cruciate ligament, it may be both ligaments, and there are other anomalies that occur in the knee, as has been pointed out in an article several years ago now that talked about the bony and ligamentous additional anomalies that are present when you have congenital absence of the anterior cruciate ligament. So what I've done in my period of time is to give you an overview of problems of the anterior cruciate ligament. Again, I want to thank first the outside speakers for a spectacular job. Outside only that they're not me, they're all inside. They're all part of a terrific bone section that we have here. And now we're going up to 10 bone radiologists, so we are really quite stocked with good bone radiologists. I want to thank all of our technical support. They've done a great job. And for the thousands of you who are listening from other countries around the world, I thank you for listening. We've gotten some of your critiques on the technique. It seems promising. We've got to work out a few things before we use it, but thank you, and also thanks for emailing us some very difficult questions.